Good evening, friends. On the onset, I would like to thank the organizers for giving me this opportunity to present on this great event. Thank you very much. Let's look into the essentials of radiation therapy planning and delivery of SBRT spine using a linear accelerator. I would like to brief on the contents. I'll be speaking about Linac requirements, not in very much detail, QA requirements for the Linacs and immobilizations, and the imaging requirements for spine SBRT, and some of the examples plan which we carried out at our center, and the conclusion. The Linac requirements. General use of the energy is 6x FFF, which is mostly used for a spine SBRT, which is one of the requirements because of the sharp dose fall requirement. And the high definition MLC, the general used MLCs are 2 to 3 millimeter at isocenter. We have something called TrueBeam STX, which gives me 2.5 millimeter leaf width at isocenter. Cave imaging is a must, and the CBCT acquisition capacity is also a requirement. And the 6D couch, it may be useful sometimes, it may not be useful, also depends on the center's immobilization techniques, what is being followed in the center. But it is advised to have 6D couch for spine SBRTs because, again, because of the sharp dose fall requirements. And the license to carry out rapid arc or volumetric modulated arc therapy capabilities. The SBRT Linac requirements, as per the task group 142 by AAPM, the tolerances required or to be maintained in the machine is different. The moment you introduce SRS SBRTs, the mechanical isocenter or the collimator isocenter, or the gantry rotation isocenter, or the couch rotation isocenter, they all should be less than 1 millimeter from the baseline. This is actually very tough to maintain. The laser localization, again, from 2 mm to 1 millimeter, it's reduced for the SBRT Linac. The collimator size indicators, the couch position, if you see, it's 1 millimeter and 0.5 degree, which is very tough for a period of time when the Linac becomes old, especially these 6D couches, they tend to give more errors. So maintaining at 1 millimeter at 0.5 degree is a tough challenge for a physicist. And the tabletop sag, 1 millimeter at the good weight at this tip end of the couch. Some of the quality assurances requirements, I'm again saying I'm not going into detail. The quality assurance, one of the basic requirements is Winston-Lutz test, which is very well established in most of the centers. Now we know how to perform this with the help of a gapchromic film. Now there are special strips available for that. Check this for all the beam angles or maximum beam angles and perform this. The moment Winston-Lutz test, we think that, okay, this is only for cone-based SBRTs, but it's not like that. The MLC-based also need to get into this test, and especially if you're using tertiary MLCs, like the MLCs are getting attached to the linear accelerator, then every time when you attach the MLC, you need to perform this test. In the absence of that test tool, now the vendors are giving a different one, like this is a modified Winston-Lutz test. It's a small box where you get inside the box, you have a lead small tungsten bearing, where you can see the images of that in EP directly. The CT scan of the phantom and plan for at least 0 to 90 degree gantry angles, like the two nominal angles for the smallest available collimator size, and expose the EPID and see how correlated images are seen, like the 0 versus the other gantry angles, and see whether these particular the image of the bearing, whether it is moving inside the square box. That's what needs to be seen. And it all should be less than 1 millimeter. This is one initial time work when we are installing or commissioning SBRT program in the center. The site physicist, I'm not getting into the detail of this again, as I said, the site physicist needs to be very, very careful about the dose measurements and the selection of proper chamber, because you're talking about here less than 2 centimeter field size MLCs. So the output factors are the one which are mostly influenced by the chamber size So make sure that you have the proper one. There are thousands of materials available for this. You can always refer them and get the best one. In the absence of a very big chamber, don't worry. There are some cheap options available, like the gapchromic films, but the physician should know how to commission the gapchromic film. There are some, the free available software like the ImageJ is available, which is freely available, which can be used for extracting the 3 different channels of the image, whether it is red, blue, or green, and we can decide on the dosimetries based on that. Once these commissioning processes are done, the basic and very important step here is the end-to-end testing. Here we take any one of the existing phantom. There are thousands of, there are many phantoms available in the market, but they're very expensive. For example, this one is a very expensive phantom. You don't really need them if you are having budget constraints. We can actually look into some local design phantoms, or you can have whatever the phantom you can design it. Do that. The only requirement is you should be able to place the film in that, and you should be able to place the chamber of your measurement technique in that, and make an immobilization for that phantom. Go for the normal procedure, how you're going to treat a spine phantom or spine patient. Do the immobilization, do the CT imaging as per the protocols. If you want to go for the MR, go for the MR and fuse them also, and do the contouring for that. Do the treatment planning and deliver it with the linear accelerator, and check the dose delivered is accurate enough to be continued or not. This is what we call as end-to-end testing. So this is must. Once you commission the linear accelerator, once we do all the tests, finally you validate your process by doing end-to-end testing. Coming to the second, the immobilization, the aspects here. There are 2 concepts again, the frameless and with the frame. The frameless, what we follow in our center is, we use a long head and neck thermoplastic mask for lesions up to about C6 to T1 vertebra. If the lesions are inferior to that, then the vacuum cushions for the lesions below T1 with the knee rest and the arm support is the choice. What we have identified in our center as one of the best systems for immobilizing the spine cases. If you're having this, the body frame or the frame-based stereotactic system, which is a little cumbersome to use, but they're good in the absence of, you have a very good linear accelerator and you have 6D couch, then I don't really find any way of using this, because 6D couch does a lot of things. Here, one of the issues what we used to face is the patient and this particular, the localizer is not in touch, they are separated. So the difference of them will definitely come in the image itself, and adjusting back the patients to match either the anatomical matching or a match with the fiducial markers is a question actually. So that has to be, it has to be validated in the center. It needs to be checked again and again. There are a lot of issues involved in that, which we discontinued using this particular product in our center. This is a typical immobilization what we use in our hospital with the full body immobilization system, the Vaculock. A patient is lying comfortably with that. Coming back to the CT simulation, the must images like the diagnostic volumetric MR images of high resolution MR images with a very good capacity to fuse the images. One of the issues what we face is the image fusion. But the advantage here is the bone matching is good enough. If you are able to match the vertebral columns very easily between MR, CT, or PET, you are almost done with the work. That is the advantage compared to any other places. The PET images are very advantageous here. And the CT images, we usually go for about 0.625 to 1.25 millimeter slice thickness, and a good image fusion software is required. So this is one of the examples which we did in our hospital. It's one part of the vertebral body is picked up nicely here with the PET images. That has been contoured by the clinician, but the whole of the vertebral body is, the body of the vertebra is also included in the contour. The spine, the whole spinal canal to whatever best extent is being included. So this is how it is transferred back to the CT images. During planning, I placed a full 1 arc with the 6 FFF beam energy. And this is how the optimized plan is. You can see the very high or steep dose gradient towards the spine here. And this is how you can see here, actually, the dose gradient here. The dose falls from 21 gray to about 600 gray within 2 mm. So our prescription is 21 gray in 3 fractions. That's what we conventionally follow in our center. So what I observed is we can reduce the dose by about 10 gray per millimeter with this high definition MLCs. So the normal structure constraints, we follow task group 101 recommendations, where the 3 fraction dose constraint here is 18 gray threshold of 0.35 cc spinal volume and the medulla. And the max point is 21.9 gray. Here the max point, when they say they are looking at 35 millimeter cube voxel sizes, so that has to be calculated by the physicist initially. What is the vocal size you're getting? And based on that voxel size, please look for the max dose point. Don't look for just the Dmax, whatever the DVH or algorithm shows, that may not be calculated accurately. Look for one voxel size and look for that particular volume and look that as the max dose for your plan constraint. So this is the DVH of that. We have satisfied almost all the criteria of that particular document. This is another case again. Here, what I do is, once the PTV is generated with in this case, they have given about 5 millimeter PTV all around. And towards the spine, actually, we created a gradient. We created by trimming the PTVs towards the spine by about 1 millimeter. And instead of full arc, I used partial arcs in this particular case, so that I don't need to come from the opposite side at all. And this is how the ultimate plan is generated. Here also the dose gradient towards the spinal cord is, in this particular angle, is very good. And almost all the criteria, like the 18 gray less than 0.35 cc also is being reached in this particular case. And this is another, the spinous process instead of the vertebral, this body. The whole of the process is being, the spinous process has been covered in the target. If you see this particular area here, with the uniform margin of 2 mm, what we have given, it gets inside the spine. So what we did is we trimmed here by about 1 millimeter away from this actual spine. And this is how the trimmed PTV is. And we optimized for that. So to be on safer side, I created 2 rings around the target by giving 3 mm and 5 mm margins around the target, so that I can give a special constraint to that to reduce the dose spillage all around the vertebra. So this is how it is. But what happens is when you plan like this, when this is of course planned with the full arc, you tend to get a very high skin dose in this particular area. So you need to give special consideration there. So we marked that particular locality here, the skin, and give a dose constraints less than about 8 to 10 gray, so that the skin dose, the skin of the patient, is safe and patient won't come back with the blackening of the skin. So this is how it is. All the constraints again, the 18 gray volume is less than 0.35 cc, and the max dose was 21.85 instead of 21.9. We could just match that particular constraint. And the dose gradient again, if you see here, they're very, very, very sharp towards the spinal cord. And this is the entire vertebral body. This is another case where the entire vertebral body is to be treated. And this was pretty simple compared to other cases. All the constraints have been reached. If you see here, this particular section, there are 2 horns and 1 well. So what happens when you set up this particular patient in the image, in the treatment, this one can shift in any one particular direction based on the setup of the patients. So just imagine this is shifted either towards left or right. Patient is going to get the full dose for that particular fraction. So this is very risky. So the safety couch helps us a lot in this particular situation with a very good CBCT images. This is a CBCT image of the patient, and image matching was done, and we do absolute matching of this, and again repeat the CBCT and check whether the matching, whatever applied, is properly done or not. Then do the subtraction of the images and make sure that at the spinal level, actually everything is blue, that means the matching in that particular area is perfect, then actually we are comfortable to go ahead with the treatment. This is one very interesting case where the spinal AVM, recently we treated this particular case. It's extracranial AVM case where we did the high resolution MR and mark. You can see in the image itself, the spine is pushed towards the patient's right. And this is the AVM area. MR angio and all those imaging was done for this. And this is how the PTV, we created this with CTV and PTV of 1 millimeter was given all around, but here towards the spine, we restricted to 0.5 millimeter PTV. So this is how it is in the CT image. This is planned with a single arc with 6 FFF beam energy. And this is the dose distribution of that particular patient. If you see here, I intentionally created a heart in this area actually, so that even if there is a small deviation of the patient setup up to 0.5 millimeter or 1 millimeter, this heart is not going to be lying on that. This is one of the important aspects in the planning. So when you create a plan, definitely all the planning systems will try to push the heart in the periphery or the center based on your algorithm. But where to get the heart is also a choice. We cannot get heart towards the spinal cord. We try to move the heart towards the opposite side of the spinal cord so that you anticipate some movement in the left-right region, still the spine is safe. This is what we achieved finally. The total dose given to this particular patient was 26 gray in 3 fractions, and the Dmax of spine achieved was 22 gray. 21.9 is the limit, but 22 gray. And 18 gray volume was 0.05 cc. This is excellent, actually. Here, the contouring was very complex for, we have to involve the neurologist for all our cases. In this particular case, the spine PRV is getting 24.5 and heart is away from the spine. This is what we have achieved. And further down, once the planning is done, before the treatment, we perform the quality assurance. We may use any of the existing system you have. What we use in our center is the polarimetry, because the resolution of our panel is very good, and we can go up to sub-millimeter accuracy with this particular aspect in this particular case. So we do with the 2% 1 mm or 2% 2 mm criteria of gamma passing, and we ensure that all our cases are getting about 98% plus in the center. So this is how we maintain it for beam. So ultimately, we need to understand all the required, the uncertainties involved in the process, like the Linac machine isocenter, Linac radiation isocenter, image reconstruction isocenter, the matching from isocal point of view. That means the radiation isocenter to the KV beam isocenter. What is the difference between them? Whatever we do, we cannot reach this particular blue circle here. We cannot reach the diameter of this blue circle for less than 1 millimeter, whatever we do. So what I mean to say here is ultimately we need to treat the patients with that uncertainty. One of the safest methodologies is to create a PTV and make sure that PTV margin is not less than about 1 millimeter all around, and treat the patients with that aspect, because we know that the uncertainty is always there with whatever technique we use in our linear accelerators. So thank you.